Welcome everyone. You're watching the Academy of Online Radiology Education ultrasound blog for November. I am Jeff Guccione, a chief resident at the University of Texas at Houston. And of course, before we begin, I would like to take a moment to recognize these wonderful 4 senior editors who have helped out with this process and make it possible. All right, so the first article this month is a meta-analysis published in Hepatology International, which is looking at contrast-enhanced ultrasound LIRAD's use in patients who are high risk for HCC. So it included 8 studies with 5,428 observations with contrast-enhanced ultrasound, and the studies had to have had a specificity and sensitivity listed. They looked at LR5 observations specifically. So as you can see, the sensitivity for contrast-enhanced ultrasound is 73% with a confidence interval of 65 to 79%, and the specificity was 95% with a confidence interval of 91 to 97%. So this group specificity is actually very strong at 95%, which is important when the use of LIRADs. The Journal of Ultrasound and Medicine brings us this great article about renal graft dysfunction in early post-transplant period. So they set out to see if ultrasound is effective in the diagnosis of renal transplant complications in the early postoperative period. So parenchymal complications that they looked at included acute rejection and acute tubular necrosis, or ATN. So they had 105 patients that had a transplant kidney in their study period, and they looked at Doppler ultrasound, shear wave elastography, and contrast-enhanced ultrasound, as well as renal scintigraphy, and they looked at a number of parameters and indices with those 4 techniques. So what they found overall was that 18.1% of patients experienced graft dysfunction, and of the many things they looked at, the renal interpolar artery peak systolic velocity was significantly different in those who had graft dysfunction versus the controls. For example, it was higher in the acute tubular necrosis group, and the peak systolic velocity was lower in the acute rejection group, which again were significant. As far as contrast-enhanced ultrasound goes, they looked at the time to peak ratios, which were significantly different in patients who had acute complications in the post-transplant period versus those in the controls. And of the many other things they looked at, there was no significant difference in the other parameters or indices with any of the 4 techniques. Barzilay et al. Via AJR brings us this article about contrast-enhanced ultrasound usage to detect early vascular complications in pancreatic grafts or transplants. These vascular complications include thrombosis, stenosis, or breakdown of the anastomosis, and usually occur early in the post-transplantation period. So to evaluate the contrast-enhanced ultrasound, they compared it with color Doppler ultrasound, which is the standard for evaluation. So they did have 34 patients who had these findings confirmed with repeat surgical exploration, and 28 patients in the control group. They used 2 radiologists to evaluate, and the inter-observer agreements were calculated. So in the table at the bottom, you can see contrast-enhanced ultrasound on the left and color Doppler on the right, and you see the sensitivity of 83% and 83% for reader 1 and reader 2 was better than color Doppler ultrasound for sensitivity. The specificity was kind of a wash. As you could see, it's very similar between the 2 groups. However, the negative predictive value of 97% for reader 1 and reader 2 was a little bit better than the color Doppler ultrasound group. They also looked at the inter-observer agreements, as I said, and that for contrast-enhanced ultrasound between the 2 radiologists was modest, but it was higher than the color Doppler ultrasound, which was 0.54 compared to the 0.28 for the color Doppler ultrasound. So overall, they summarized that contrast-enhanced ultrasound may be a good tool to detect these early vascular complications. And this is an interesting article which examines the use of ultrasound compared to MRI in the diagnosis of placenta accreta spectrum. So ultrasound is the standard modality to evaluate for placenta accreta. However, there's been conflicting evidence in the literature for some added benefit of MRI. So what they did is they looked at ultrasound and MRI with 23 cases of diagnosed placenta accreta post-delivery, and patients who had both an ultrasound and MRI prior to delivery. So the sensitivity, as you see, was higher in ultrasound, not surprising given what we previously know. The specificity was also higher compared to MRI. However, when they did a post-analysis evaluation simulating a structure reporting system, which they did use a structure reporting system for the ultrasound cases, the MRI findings increased with the sensitivity to 96% and 60% for MRI, which was comparable to the ultrasound group. So MRI may have a role if there is use of structure reporting, but more research is needed to determine this role. So endometriosis can be a debilitating disease and can affect the urinary tract, particularly the bladder being the most common location. So this article wanted to see the use of transvaginal ultrasound and how that compares to the findings at cystoscopy to see if transvaginal ultrasound can predict those cytoscopic results, since the cystoscopy is the gold standard for diagnosis. So there were 22 patients in this study with bladder endometriosis diagnosed on transvaginal ultrasound and a accompanying cystoscopy. They primarily looked at detrusor muscle involvement, although they did look at a couple other things. And what they found was that 41% of patients had partial detrusor involvement on transvaginal ultrasound and had a normal cystoscopy. And 69% of the others had transmural detrusor muscle involvement and had an abnormal cystoscopy, being that an implant was seen at the time of cystoscopy. And cystoscopy may not see the partial involvement because it won't involve the mucosal surface on the inside. So ultrasound, they determined, had a 100% positive predictive value of cytoscopic findings, which may be helpful for examination prior to cystoscopy. A review article published in Abdominal Radiology, this looks at liver elastography and the current practice as it relates to liver fibrosis. So they examined strain elastography and shear wave elastography, as well as discussing the interpretation and findings in numerous disease processes such as non-alcoholic fatty liver disease. They also briefly touch on future applications such as the use of artificial intelligence assistant to help with diagnosis. Interesting article, and I highly recommend. Another AJR article looking at ulnar neuropathy and optimal diagnosis. It is a meta-analysis looking at 19 studies with 1,961 examinations. Ulnar neuropathy usually arises at the elbow cubital tunnel as a result of stretching or compression of the ulnar nerve. So they wanted to see the optimal technique for measurement with ultrasound to diagnose ulnar neuropathy at the elbow. So what they found looking at all of these articles was that the highest specificity was using nerve ratios at the level of the cubital tunnel and below or above with an 89% specificity. The highest sensitivity at 80% was cross-sectional area measurements at the medial epicondyle with a cutoff of 10 to 10.5 millimeters squared using those two dimensions of measurements. A higher diagnostic performance was seen with the cross-sectional area measured at the medial epicondyle. And finally, another big finding was that for every 1 millimeter increase, millimeter squared increase in cross-sectional area was associated with a 36% increase in the diagnostic odds ratio. So this article gives some very good tools to be able to help us diagnose ulnar neuropathy using ultrasound. And finally, a look at temporomandibular joint disorders. The authors here wanted to see how high-resolution ultrasound compared to the gold standard currently used of MRI for the diagnosis of TMJ disorders, which could be disc displacements or degenerative changes. So they used both 13 megahertz and 20 megahertz probes for ultrasound, and they compared that to the MRI standard. So they had 50 patients which were enrolled prospectively and had both an MRI and ultrasound obtained within 1 to 7 days after clinical examination. So you can see disc displacement on the left and degenerative changes on the right with the sensitivity, specificity, and so on. The sensitivity was a little bit higher for disc displacements compared to MRI than it was for degenerative changes. Specificity was kind of even for the two, but a little bit higher in degenerative changes at 92%. Positive predictive value was higher in disc displacements for both probes, and negative predictive value was a little higher at 88% in the degenerative changes. So one takeaway here is you can see that 13 megahertz and 20 megahertz probes had a very similar diagnostic performance compared to MRI. MRI was superior in a number of areas, particularly sensitivity, but high-resolution ultrasound may be another tool to help diagnose temporomandibular joint disorders, particularly since it is more accessible and can be cheaper and quicker. And that is all I have for you this month. Thank you for watching and for following us at the Academy of Online Radiology Education. Please follow us on Twitter, Facebook, or LinkedIn if you haven't already, and I look forward to seeing you back next month.